Does anybody have specific eligibility criteria? For example, Jessica, is anyone able to access your services if they've suffered because of Harvey, or do you have income eligibility requirements? If you could each speak to if there are any eligibility requirements people should know about.
Sure, so I can start. So we do not have eligibility requirements right now. I will tell you a little bit more. Ever since Harvey occurred, we did start providing services to the community and did 2 free sessions, 2 no-cost sessions to clients that were coming in that were suffering from Harvey-related issues. So just knowing that they had been impacted in some way, maybe family had moved in and that was causing some stress. And then now, since this new grant, we actually are providing services in the schools. And so that is the eligibility that our counselors are in the schools, and the students are coming and seeing the counselors there. But
great. What about at Baylor and Harris Health? What sort of eligibility requirements are there?
Yeah, absolutely. Within the Harris Health system, you have to be a resident of Harris County. There is a couple-month process to document that, so you're essentially given a couple months, which, wink, wink, if you aren't yet, you'll have some time to get sorted out. With insurance, you're able to access services, but if someone doesn't have insurance or isn't able to cover services, then essentially we make it work, is probably the best way to put it.
Okay, what about for MHA and counseling?
So for the counsel and recovery, I would say that in the same respect is there's no specific eligibility requirements except for that you live in the city of Houston and or Harris County. And then number 2, that you were impacted by Hurricane Harvey. And number 3, that you're willing for that to be part of your services as appropriate for you when you come in. And so those are the 3 main things that we would be looking for. Otherwise, it's pretty broad. And I should say, I forgot to mention before too, as far as eligibility goes, is we service adults and adolescents and then children who are impacted by a loved one's addiction. So it's not just the adult or the adolescent who may be engaging in substance abuse or compulsive behaviors, but the services are for the whole family. So one person can come, but their spouse can come, their child can come, etc., and learn about the disease. And those services also go out in the community. They're not just at the main office.
Thank you. And we really don't have any specific eligibility requirements. As I mentioned, our services are available for anybody who's going to be in that position to be working with, coming into contact with individuals with mental illness, as well as for the community at large. And we can provide those services at your locations, whether that's at a school, at a clinic, at a church, or at our own office. So we have a lot of flexibility that way.
Great. So what else do people need to know about your referral process? Do you want to start off? Dr. Schwartz?
Yeah, sure. Eric. Dr. Schwartz is my dad.
Okay, sorry, Eric.
Yeah. So apparently I look more like him every day. It's distressing. But let's not tell him that. So there are a few ways to get in, and what we wanted to do is make this as seamless as possible. One of the ideas with having primary behavioral health embedded within primary care clinics is to reduce barriers. It's hard enough to go to an outside setting that has psychology, psychiatry, especially if someone isn't familiar or well versed in those resources. So we just want to make this part of everyone's overall care. So how it would work is that they go through the basic Harris Health patient hotline. They would call up depending on which center that essentially proximity. And then from there, if they were affected by Harvey and are looking for behavioral health services, would be triaged to us. Second thing that we're going to do is have a direct call-in service. So a cell phone that we're in the process of getting, because what I've learned is that nothing at Baylor happens quickly, especially purchasing a cell phone with a number. But that will be made available to primary care providers and other community folks, whether it be religious organizations, as one example, where if there's someone who might merit services or warrant services, they can directly reach a person who will be identified screener, who in essence will be trying to connect them within the Harris Health system. And then the final would be a direct referral, whether it's from a primary care provider or someone else within the system. And a big part of what we're going to be doing is really beating the streets to try to increase knowledge about how to get in, who, you know, it's pretty broad as my colleagues about who can get in, but again, making it easy and immediately accessible.
And we also obviously have your contact information on this referral sheet so that if there is a case manager or another provider that sees someone in need of services, they can connect with you. Okay, so everyone else, talk a little bit about your referral process.
Sure. So once a client or a partner has called our agency, we actually do have an appointment services department that would take the call, ask some questions, and then assign the client to a clinician. If it is a student at one of the schools, like I mentioned, we would have the clinician on site and we would make the office aware. But we might, like over the summer, we might get some clients that come to our central office or one of our other offices. And so, again, we would just assign them to the clinician. We do have specific flyers that we created that we actually will pass out at the school so that they can get our contact information.
Great. Anyone else want to comment?
Excuse me. So people can call our regular number and be able to receive the services. They just, if they say that they were impacted by Hurricane Harvey, and again, they'll be asked those questions that we refer to. And I'm not sure, I don't have the paper in front of me about what numbers are on there, but the Council on Recovery, we advertise our main number. We chose not to have a special number specifically because we don't want to confuse the people who are normally calling us on their own for services. At the same respect, David Sunday, and if you don't know him, like I said, you will. I promise you that. And people can also, you guys can also call him directly. So if you have someone who you think needs services, okay, not every single one of you.
He's turning redder and redder as the time goes on.
But our whole point was that we also don't want people to get stuck in our phone system. And so we encourage people, we want them to be able to access the services in whatever way is necessary. And as was just said, we also have a screening and an assessment process that starts as the first service. And that can actually be a motivator for other services. So I always tell people, don't try to tell someone you're coming there to stop using substances and to stop your addiction. Just go talk to someone. That's usually, so I would say the best way for referral and for access is for someone to call and say, I need help, I don't know what it is. And David or the person who answers the phone would help them through that, and then also help them know if we can offer those services right where they're at in their home.
For us, it's very simple. You can contact us by phone or online, and you can reach out to any of us, myself, my colleague, Alex Cadavid. I believe her contact information is in the paper, so you may be getting some emails, but and we'll connect you. Talicia Johnson is our program specialist who coordinates our community education, and Josephine Engels is the coordinator with our Center for School Behavioral Health, who would work with you if it was services within the schools that you were looking for, but any of us can make that connection for you.
Great. So let's talk a little bit about some of the symptoms that you look for. If you're a case manager or you're doing home repair or providing financial assistance or transportation assistance to a client, what are some of the signs of distress or symptoms that you ought to look for, Jessica, to begin to signal that maybe this person does need behavioral health resources?
So one of the main things that we have really observed in clients is like a lack of concentration, a lack of focus. Of course, the obvious that you've probably heard of, the anxiety, lack of motivation. In kids, we're seeing a lot of fear, some attachment issues, not wanting to leave their parents, maybe wanting to go into your office with the child, with their parent, crying. We've seen some PTSD and some acute stress disorders as well with that. But I would say definitely if you have a client in your office and you're really seeing that lack of focus, very stressed, those are moments when you can really tell the client, that there's someone they can talk to, that there's some organizations that are willing to help, and really encourage them to give it a try. I know sometimes if they haven't received counseling services in the past, there might be some stigma around it, but giving it a try and talking to someone can really be that first step to them beginning to let out all those things they've been holding in, all the trauma.
Mary, any particular behaviors that people should be looking for that might indicate that they need your services at the council?
Sure. A lot of times what we see, especially after a significant trauma, is compulsive behaviors seem to increase because people are seeking control of something. And even though it is really an out of control behavior, it feels like you're in control. So that can be increased substance use, increased alcohol use, increased smoking, increased pill use, etc. It can also be increased sexual activity and harmful or risky sexual activity. It can be increased spending when you don't have the resources. I'm sure I probably think of others, but those would be some of the increased gambling. So anything that seems to be out of the ordinary and seems to be being done compulsively and also seems to be being done under high stress and under the guise of trying to calm yourself, I would say would be the things to look for as far as behaviors go. And then the perfect combination would be what you said and what I said combined. You'd probably end up seeing a combination of both.
Okay. And let's talk a little bit more about advice around referring someone who's resistant. If any of you want to answer that, just what have you seen to be helpful? If someone, oftentimes there can be a cultural stigma associated with seeking help. Overall in the United States, I think there's a stigma in talking about mental health issues, but then particularly in certain cultures, there can be less openness to asking for counseling. So what are some of the words that you feel others can use to help make it open that door for referral that have been effective in the past? Anybody have a magic bullet?
So one of the things during the first few rounds of the Harvey grant, we did get disaster case management, and one of the things we did is we paired up with the case manager. When a client would come in, if we saw that maybe the client was struggling with some of the symptoms that I mentioned, we would have one of our counselors go in and talk to the client for about 5 minutes just to introduce the fact that we did have counseling and that their emotions were very normal given the circumstances, and so that really helped. And again, speaking to them in their language and being very respectful of their limitations and boundaries, not going too far if they didn't want to go too deep into any of the issues. So
step by step easing into it sounds important.
Yes.
Other comments?
Yeah, I think you need to be mindful about where the services are best delivered. So it may not be, and likely isn't, within a psychological or psychiatric provider's office, but again, maybe in a primary care setting or in a religious setting or a community setting. You also want to think about what kind of the need is. So for example, from a treatment perspective, when we talk about therapy, we tend to think of it in terms of a pretty robust dose, 10 sessions, let's say. A lot of people just need to talk with someone a couple times, and that can be very helpful. You want to make sure that, truthfully, I think sometimes mental health professionals, we get a bad rap because we're not as cool as the four of us up here. I mean, like I want to but it's just being matter of fact. Like, hey, Mary, I think you said it well. Like, why don't you just go talk to this dude? Storch is pretty cool. Like, he's got a good head of hair, and let's see. And so you kind of just try to make it very laid back, and then I think it's incumbent on the provider to do the exact same thing, and that's one way of dealing with it. The resistant piece is really tricky, and with this kind of string of school shootings is just one example. And what I think we see are these people who aren't who weren't identified as being at imminent risk to self or others, and they live in the community. And that's a challenge and a gap that we have in terms of identifying folks who could harm self or harm other people, which fortunately is less frequent. And when people are resistant, it's hard to get them in, but I think that foot in the door, as Jessica was saying, with meeting them where they're at, not trying to be so kind of over the top, but just hey, here we are. And what I find is it's an approach like strike while the iron's cold. You know, if you push too much, then it kind of pushes people away. But when you give, you know, here's some information. If you want to call. I'm just going to be sitting here eating chocolate, waiting, and you know, give it to them like that. And I think they're oftentimes a better chance of outcome, successful outcome.
It's interesting. That's really sort of counterintuitive in some ways, isn't it? The idea that maybe, you know, actually not being as pushy might be a better approach than really being like, you look like you're in crisis, go, you know, escalating the situation. So I think that's really interesting advice. Alejandra, can you talk a little bit about the work that the Behavioral and Spiritual Health Group is doing through the LTRC?
Certainly, and I don't know if everybody's familiar with the LTRC, the Long-Term Recovery Committee. It's being coordinated out of United Way, and they have a number of work groups. So my colleague, Talicia Johnson, co-chairs the Behavioral and Spiritual Health Work Group, and they have a number of things kind of stirring in the pot. One thing that they're doing is trying to really gather some information about those specific post-Harvey behavioral health resources that are out there. Information like the fact that Family Houston is offering some free sessions. We have databases and brochures with information about kind of what behavioral health services are out there, but we know that eligibility requirements sometimes changed after Harvey. Additional services are available. They may be available free, etc. So trying to really gather a lot of that information into through a survey that's gone out. So in order to be able to get something that we can put in the hands of case managers, in the hands of those who you know, may be recognizing those symptoms that Jessica and Mary mentioned, and those signs, and saying, okay, here's where you might go when someone is open to that, to make that that referral process a little bit easier. So hopefully we will. We're really working right now to get that survey out into the community, and hopefully we will have something like that we can put in your hands pretty soon. And I think we could combine that with some of the work that was done on the behavioral health cheat sheet that's in your packets, which is really good to get into the hands of those people who are in those key gatekeeper positions. And then the Long-Term Recovery Committee is starting to look right now at also how can they partner with other sectors for some kind of non-traditional approaches to healing and recovery. So looking at some potential for partnering around arts, possibly around a sports initiative. Those are all conversations that are in the works, so we'll definitely circle back with that. There may be some great opportunities to get involved there.
Great. Well, in our last few minutes before we open it up for questions, are there any additional resources that any of you are providing that you haven't had a chance to share yet, that you feel that this community of providers and partners ought to know about? Anybody?
Sure. So through Harris Health, we have a psych ER, which hopefully we won't get much use. But then differing levels of care, which is something we talked about, that not everyone is going to be able to have just basic outpatient, but may need more intensive services like an intensive outpatient program. The issue with dual diagnosis is a very significant issue, and oftentimes if someone is presenting with a substance abuse issue, it complicates intervention for the behavioral health or psychiatric issues. So having resources and partnerships like what we've discussed are really critical to be able to deal with both problems, because otherwise you're kind of spinning around trying to figure out which one to go at. So those are a few things that we're offering at Baylor and Harris Health.